Hi everyone, my name is Alex. I'm a third year UNISA psychology student and we are doing schizophrenia and schizophrenia spectrum disorders this week. I will catch up with depression after this video because I missed last week. Okay, so let's run through it as fast as we can. If you like this, please like, share and subscribe. Any problems, put the comments in. Remember, on this web page, you can go through old exam questions. And see everything that I've done on here. I didn't have time to do little memory questions for these last two. All right. So if we look at schizophrenia, there are positive symptoms. So let's look at the first set of positive symptoms are the delusions. What is a delusion? It's a false belief that is firmly and consistently held. Okay, lots of people have those. But delusions are something different to mainstream, eccentric, and unusual beliefs. Okay, they are deeply irrational and they lack insight. People often lack self-awareness, most especially of their asociality, their delusions, their reduced affect, their hallucinations and thought disorders. Okay, so that's the thing about delusions. They're not rational, they often lack insight. Okay, so common delusions are delusions of grandeur, thinking I'm incredibly important in this world, a famous person and so on. Delusions of control, normally about being controlled from the outside. Someone putting thoughts into your head, someone controlling your body, someone controlling your environment. Delusions of thought broadcasting, thinking other people can hear your thoughts or that they're being recorded in some way or broadcast on the radio or the TV. Delusions of persecution, paranoid ideation, believing people are out to get you. All right? Delusions of reference, thinking it's all about you, that everything that happens around you is about you. Okay? Delusions of thought withdrawal, someone is taking thoughts out of my head. Capgras delusion, which is quite rare but alarming, when you believe that someone you know or love has been replaced by an identical duplicate who is pretending to be them. So you can imagine how uncanny and disturbing that must feel for the person and also for the loved one who is saying, but I'm me, and not to be believed. Okay. So often a very frightening experience for the person with the disorder. Hallucinations. Okay, so hallucinations are distortions of the senses. So you get auditory hallucinations. This is the most common, specifically around hearing voices. The voices are more often than not malicious, but may also be benevolent, okay, or both of these. Visual hallucinations, okay, there's different kinds of visual hallucinations. Olfactory, where you imagine that you can smell smells. Tactile, you can feel things like crawling insects. Gustatory, a bad taste in the mouth. Okay. Disordered thinking, another positive symptom. So a person with schizophrenia or schizophrenic type disorders will have difficulty focusing on one topic. They will constantly shift from one topic to another without a logical or meaningful connection between the thoughts. Very tiring to listen to, and many people don't relate and don't want to listen, so it's quite lonely. The person may struggle to grasp abstractions like metaphors and figures of speech and take everything literally. Miscategorization or over-inclusiveness, putting things together in your mind that other people wouldn't put together, so seeing it as all connected. Incoherent communication and bizarre behavior. All right. Then we're looking at psychomotor abnormalities. So there's catatonia. Catatonia may be excited or withdrawn. So catatonia, there's three types. So there's lack of responsiveness to the environment, peculiar body movements and postures, strange gestures and facial expressions. Okay, here's a picture of someone with catatonia. You can see this is withdrawn catatonia. And there are other photos of people looking really strange. You get long periods of non-responsive stupor, immobility or mutism. And this can even be life-threatening if the person is not eating. Then you get excited catatonia, which can be quite scary for the people around that person because they can actually become violent and dangerous extremely agitated, hyperactivity, uninhibited behavior, may run until they collapse, may not stop talking. Okay? Right, so those are all the positive symptoms. They're positive symptom meaning there is a symptom which is added to behavior. Okay? Let's look at negative symptoms. Negative symptoms are like when there's a negative space where someone else would normally have a behavior. All right? So it's lack of behavior. So inability or reduced ability to act, communicate, or enjoy life. Okay, so negative symptoms are associated with a poorer prognosis, and these can be the major symptoms of schizophrenia. So let's run through these 5. So there's avolition. Volition meaning motivation or desire to act or move. Unable to act or persist in goal-directed behavior, so not wanting to do anything. Alogia, lack of meaningful speech. So you can remember logia, logic, being able to speak logically. Asociality, lack of desire to socialize. Anhedonia, lack of pleasure. This is also a big part of depression. Diminished emotional expression. So lack of facial expression, lack of tonality in the voice, lack of emotional expressiveness, just blank. Okay? All right. So those are the negative symptoms. Right, let's look at the diagnostic criteria. As always, timing is everything. And I believe that just about every UNISA 1 question assignments is always going to look at the timings. We must have the timing in our heads. So you need at least one of the following 3 major criteria. That's delusions, hallucinations, or disorganized speech. So it's DHD, delusions, hallucinations, disorganized speech. Okay, and at least 2 of delusions, hallucinations, disorganized speech, or gross motor disturbances or negative symptoms. There also needs to be a deterioration in ability to function because, of course, it's all about the stress and not being able to function. That's what these disorders are all about. Symptoms must be present most of the time for 1 month or more and must persist for at least 6 months if not treated. So untreated 6 months or longer. If it's shorter than 6 months, you're not going to get a diagnosis of schizophrenia. You're going to get a diagnosis of schizophrenia. We'll come down to it. There's 2 others. So there's temporary delusion and then there's the schizotypical. We'll see it in a moment. I've just written this whole thing. I've forgotten the name. Okay, so there's 3 phases to schizophrenia in the most typical course, okay, not always. First, there's the onset stage, prodromal, social withdrawal and isolation, neglect of personal grooming, inappropriate behavior, affect or communication. So the person just seems strange, withdrawn, isolated, not taking care of their appearance, not taking care of their personal hygiene. Active, full symptoms. Residual, the symptoms have declined and the person may return to the kind of phase of the prodromal or they may make a further recovery, okay, depending on the support that they're receiving, depending on the progression of their own mental health disorder. Okay, let's go through the dimensions. Okay. Biological dimensions. So there's not a single gene that's been correlated with schizophrenia or a single bundle of genes. There's multiple gene pathways. It is largely inherited. So the general population has a 1% prevalence, but if you've got a direct blood relative with schizophrenia, you have a 16% chance, okay, of developing the disorder, which is low overall, but compared to 1%, very high. So they've looked at people's brains. They found a decreased cortical volume and increased ventricles. These are the spaces in the brain. There are abnormal neurotransmitters, dopamine, serotonin, GABA, and glutamate. Dopamine is the most significant because it seems like schizophrenia is associated with excessive dopamine in the brain. How do we know this? There's 3 reasons. 1, antipsychotics block dopamine receptor sites and bring about a recovery. 2, L-DOPA is used for Parkinson's, in which there's a lack of dopamine in the brain. And when you give people L-DOPA, they often develop symptoms that are very similar to schizophrenia, okay? Amphetamines increase dopamine availability and are also closely correlated with people with schizophrenia. So tuk is extremely dangerous for someone with schizophrenia tendencies, and so is cannabis, cocaine, alcohol, and LSD acid. Okay, cannabis in particular, perhaps because it's such a broadly used social drug. Okay. Risk factors around pregnancy and childbirth for the child to develop schizophrenia later in life include head trauma, a difficult birth, and prenatal infections. Okay, which may trigger those genes, those vulnerable genes. Psychological dimension. Okay, if a person is socially disconnected, it seems to affect the likelihood that they're going to develop schizophrenia. If they lack empathy and all their thoughts are turned inwards, it can increase the tendency to some of the positive and negative symptoms of schizophrenia. Early cognitive deficits also seem to be correlated with later development of schizophrenia and related disorders. Negative expectancy appraisals. In other words, if you think that no one is going to be your friend, this may exaggerate your asociality, for example. Okay, because yes, it's a mental disorder, but it's also an experience of life and the world, and there's a lot that can be done to help a person with schizophrenia. Okay, the social dimension. As always, childhood trauma seems to be a risk factor, especially bullying and maltreatment from peers and caregivers. If there's something called expressed emotion, okay, negative family communication pattern, negative emotions, blame, accusations, high conflict, this will also increase the relapse rate for people with schizophrenia in some cultures, possibly where it's specifically hostile rather than just a social style. Okay, socio-cultural dimension. Okay, the more discrimination, the higher the prevalence. But this may be due to diagnostic bias, and it also correlates with poverty. Okay, the recovery model. This is something that is fairly recent. Instead of pumping people into an asylum or just pumping them full of hard drugs and kind of leaving them to their own devices as a write-off, what this is a collaborative and optimistic approach to recovery to help and support people living with schizophrenia. So the truth is that improvement is possible. Significant improvement for about 40% of all people diagnosed with schizophrenic disorders. You are not your disorder. You can find ways to cope with the symptoms. You can get empowered. You are not hopeless. You don't have to be dependent just because you have schizophrenia. There is a way to develop an independent and successful and meaningful life, and you can have meaningful social connection. Okay? So it helps people to cultivate and discover themes of hope, optimism, self-determination, self-respect, personal empowerment, and personal ownership of, okay, I've got this disorder, how am I going to deal with it? How am I going to deal with the medical profession, my symptoms, and my needs? Okay. Right. So let's look at some of the treatments. Antipsychotic medication. All right. Antipsychotic medication changed everything for people with schizophrenia. Before, they used to be locked away and had terrible symptoms that nobody could control and required round-the-clock care, which they often did not get. Now, with medication, it means that people don't have to be locked away. They're not going absolutely stir-crazy with hallucinations and agitation and so on, and being a danger to themselves and others. It is possible to get their symptoms under control. This started with the older conventional antipsychotics, Thorazine, etc., with severe side effects, and now newer atypical antipsychotics, which have less Parkinsonian side effects but have other side effects and may actually be less effective. So there's this constant battle with the medication because it's very, very, very dangerous. It doesn't help everybody. And of the people who stop taking their medication, which is like half to 3/4 of the people, 80% stop because of the side effects. Some people believe they don't need it. The sensation of that medication can be extremely unpleasant. 30% don't trust the medical system and the practitioner, which is not surprising in some cases. And 20% because someone else advises them to stop. Okay, so the side effects of conventional antipsychotics are 90% prevalent over the long term, extremely serious. Some are permanent and life-threatening. They include, okay, before we run through this, this is the nerve damage that can be done to some people by antipsychotics. And you'll notice that people who have had schizophrenia for a long time, you'll see the strange facial expressions and movements. That's not the illness, that's the medication. So these are extrapyramidal symptoms: Parkinsonism, tremors, shakiness, immobility, dystonia, slow and continued involuntary movements of the limbs and the tongue, akathisia, motor restlessness, neuroleptic malignant syndrome, which is potentially fatal autonomic instability and muscle rigidity. In other words, your body stops automatically keeping you alive. Loss of facial expression, shuffling gait, tremors, rigidity, loss of balance, increased risk of metabolic syndrome, and many, many other horrible side effects. Okay, really hard. And some of these are recoverable from, and some are not. Okay. Tardive dyskinesia is what this is called. All right. Cognitive behavioral therapy can help people. It can help a lot. Gives people coping skills, gives people a safe space to engage with their symptoms and their stresses, helps people assess and identify negative or unhelpful beliefs, and identify helpful and unhelpful responses to the symptoms. How do you deal with this brain that constantly feeds you false information? Okay. Normalizing of symptoms, collaborative analysis of symptoms and the beliefs that go with them, like ignoring hostile voices. There's a significant proportion of the population that hears voices that doesn't actually have any other symptoms. And a lot of people simply learn to ignore the voices just as if they are other people, just as you'd ignore a person who's offensive, so you ignore a voice that is not helpful to you and not reliable. Family interventions. Okay, a lot of the people who are homeless, especially before South Africa's economic collapse, are homeless because they are schizophrenic, very high levels. And this is because the families are not supporting and holding space for them. So family interventions, family support makes or breaks things for people with schizophrenic disorders. So now, mental health care, a lot of it's focused around intervening with the family. So you want to normalize the disorder, display concern, empathy, and sympathy for all family members. They're also burning out, they're also stressing out, they don't know what to do. Educating about schizophrenia, avoiding blame or pathologizing the family's coping styles, identifying strengths and competencies, developing problem-solving skills and stress management, teaching coping strategies for coping with the symptoms, and strengthening the communication skills of all family members. Okay. Right. Other schizophrenia spectrum disorders. So, this is the one I was saying earlier. Before 6 months and after 1 month, you would call it a schizophreniform disorder. Okay? If it's for less than a month, up to a month, you call it a brief psychotic disorder because you don't know if the person's going to be better tomorrow or not. Okay, delusional disorder, delusions for up to a month. That seems strange. Some people have long-term delusional disorder. So there's something funny going on there. And then finally, schizoaffective disorder, which is a mixture of schizophrenic symptoms and either major depression or bipolar symptoms. Okay, but it can't be reduced to one or the other. Both are present. So let's run through this. Let's go look at delusional disorder. Okay, for at least a month. Okay, so up to a month is not correct. For at least a month without other unusual or odd behaviors, and quite rare. And a lot of people don't seek help because they're actually generally fine. They just have a delusion. And other than that, they live normally. So common delusions. Okay, we just want this little bit of jargon. Okay. Erotomania, you believe someone's in love with you. Women more than men. Grandiosity, one is a very grand and important person. Jealousy, my husband or my wife is cheating on me. Persecution, more men than women. People are plotting against me. They're trying to get me. They're out to get me. They hate me. They want to harm me. Okay? They're doing horrible things to my vegetable garden. Somatic complaints. I smell bad. I'm deformed. I've got things under my skin. I've got an infection. I've got parasites. Nihilistic. A major catastrophe will occur. There's going to be a nuclear war. Referential. Everything that's happening around me is about me. People are talking about me. Everything I see in the street has got to do with me. The way the leaves flow in the wind is about me. Religious. Believing I'm Jesus. Believing Jesus is talking to me, although that's kind of normal for some people. And so on. All right. Loss of control. Believing you don't have control of your mind or your body. Someone's manipulating me. Thoughts are being put into my head. Thoughts are being taken out of my head. My body is being managed by someone else. Okay. All right. Brief psychotic disorder. This is for up to a month. Okay. So you're looking at delusions, hallucinations, and or disordered speech. So we've got those three again. Remember, it's DHD. So it's delusions, hallucinations, disordered speech. For 1 day to 1 month, not longer. If it's longer, it's schizophreniform disorder. Okay, it may include other psychotic symptoms as well. May be triggered by pregnancy or for up to a month after childbirth. Often abrupt and distressing and requiring hospitalization, may be triggered by either sudden or cumulative stresses. 10% of all psychotic symptoms are due to this disorder and is twice as common in women. Okay. Schizophreniform disorder. So if it's for longer than a month but less than 6 months, we've got schizophreniform disorder. Okay, so it might be schizophrenia, might not. We're going to wait and see. Okay, 2 or more symptoms, which may also include gross motor disturbances or negative symptoms. So remember that we're looking for those delusions, hallucinations, disordered speech. One of those, okay? But then you need another symptom as well for schizophreniform, so it must be 2 symptoms. Equally in men and women, 1/3 of people recover, especially if it's sudden onset, they were doing well beforehand and there's no negative symptoms. 2/3 of people who have schizophreniform disorder go on to develop schizophrenia. Okay. All right, schizoaffective disorder. This is quite rare. It affects women more than men. To get a positive diagnosis, you must have schizophrenic symptoms as well as manic depressive or depressive. So manic depressive can be confusing because it can go with a certain amount of psychosis and hallucinations. So the person must continue to have the schizophrenic symptoms, delusions, hallucinations, and or disordered speech, even though they're not in a stage of mania or major depression at the time, in order to get a positive diagnosis. Okay. All right. So that is that. So I hope this helps. Good luck for the test, and I'm going to do another video right away on depression. So thank you and bye.